Brother Najeeb? Brother Najeeb, are you there?
Assalamu alaikum. Assalamu alaikum. Can you hear me?
Assalamu alaikum. Yes, I can hear you.
Oh, good. Dr. Shoaib, can you hear me? Dr. Shoaib, Dr. Shoaib, you are muted.
Okay, can you hear me now?
Yes, perfect.
Okay, sorry about that. I didn't know that.
No, that's okay. How was
Okay.
your call?
Oh, it's still going on. I probably have to leave now in next 30, 40 minutes. And there is a patient I need to do today. But otherwise, not bad.
Okay, so we should start now.
We can go ahead and start?
Yeah, exactly. We need to respect your time.
Okay. Well, thank you so much for having me. And I will try my best to concise this topic in the few slides that number one, let me just tell you briefly about myself. I'm one of the interventional cardiologists. My full name is Shoaib Haroon Saya. I practice out of Mansville, and I practice both cardiology and vascular medicine and do intervention in the carotids and abdominal aorta. So the topic that was assigned to me, the prevention I do exactly opposite of them. Most of the time patient comes to me, they already have a disease, and I go in and try to fix those issues. So anyways, I think this is a very interesting topic, and I think most of the emphasis should be on that, so we can prevent from patient getting to that point that they need stents and interventions done to their carotids or coronary artery disease and abdominal aorta. And we spend a lot of revenues and resources on doing those intervention. I think more should be invested in to prevent those from getting to that point. So I compiled a few slides, and it's not going to actually complete the whole topic, but I'll just highlight some of the things. Let's see.
I can move the slides if you want.
Yeah, are you going to move, or can I? Actually, I was able to open this on my computer. If you want me to.
I can move the slide because now it's showing from my end now.
Oh, okay. So let me just see. Okay. So can you go to the next slide then?
Sure. It looks like it's freezing on my end now. No, it's fine. No.
Okay. So this slide basically summarizes the amount of revenue we spend on these conditions and how many lives we lose every year. So mostly about 850,000 lives are lost each year due to cardiovascular related deaths. And among them, 650,000 lives are lost because of the MIs and heart attacks. And about more than $350 billion are spent annually in taking care of those patients. So it's a huge, huge problem. Can we go to the next slide now?
Sure.
So over the last 50 years, the American Heart Association and American College of Cardiology has gone through and digged into those issues and find out some of the modifiable risk factors and some of those risk factors which are non-modifiable that we cannot change. The person is born with those risk factors, which can lead to heart attacks and acute strokes and aneurysms and so on. So among the non-modifiable risk factors, the risk factor that will stay with your life from the day the person is born to the day that he dies, our age, obviously we are all getting older, so we're not going to get younger. So the risk of having the heart attacks, the risk of having a stroke, all of those going to go higher as we grow older. Gender also is very important. Being a man increases the risk of heart attacks and strokes. Ethnicity among some ethnic group, for example, Asians, Blacks, Hispanic, they are at higher risk compared to Caucasians of having a heart attack and strokes. Similarly, family history. If someone in the family, for example, if both parents have heart attacks or both parents have a stroke, then it's very likely that the kids at some point in their life, they have a higher incidence and risk of having those issues, especially once they cross the age of 15. And we go to the next one.
Yeah.
And there is very few things you can do to change those non-modifiable risk factors. However, there are a bunch of modifiable risk factors, and they have been refined in the last 10 to 15 years. We used to have only 4 or 5: hypertension, dyslipidemia, diabetes, and smoking, that we used to call that modifiable risk factors. If you smoke, you quit smoking. If you have a high blood pressure, you control your blood pressure. But now we have a list of other risk factors that we learn that are playing a huge role in leading to cardiovascular deaths or MIs or strokes. And those includes hypertension, dyslipidemia, diabetes, obesity, smoking, poor diet. I mean, if someone has a very poor diet selection, he eats all the junk food or fast food. And one of the very interesting example is when I was in my training, my attending physician presented I think he did a presentation, and he put together a slide that he said, if you look at the AHA website, the incidence of acute MI went up suddenly. On the graph, he shows like 30 times higher in the 1964, I believe he said, 1964 or 56, something like that. And he asked us, what was the reason? What do you think what happened in that year? And that was the birth of McDonald, actually. The McDonald came in this country. And he said that's when suddenly you can see the rise in the incidence of acute MI. So all the fast food that people started eating, then people started having more acute strokes and acute MIs. Similarly, sedentary lifestyle, as people got more and more sophisticated and rich, and more automobile cars came in, our lifestyle changed. And now we see more and more people sitting from and working from home using computers. So that is also going to have an impact on patients with a stroke and heart attacks. Metabolic syndrome, again, if you're not very active, you're going to gain weight. And the metabolic syndrome is defined as someone who has in men with a waist size of 34, with the and then you have a truncal obesity, and you have a low HDL and high triglycerides. If you have a combination of four things, then you are metabolic syndrome. And metabolic syndrome increases the risk of stroke, diabetes, hypertension, and acute MIs. Similarly, obstructive sleep apnea syndrome, again, that has been more recognized in the last 15 years. Now we feel like any obese person, if you do a test, you're going to find them, they have obstructive sleep apnea. That when they sleep, they kind of quit breathing for seconds, or sometimes for maybe 20, 30 seconds. So one of the thing that we realized in patients with the obstructive sleep apnea syndrome was that they have a higher incidence of atrial fibrillation, the irregular heartbeat, and stroke and sudden cardiac death. Similar, next slide. Oh, can you click the next slide? I don't know what happened here. Okay, right there. So the other modifiable risk factors are rheumatoid arthritis, lupus, and all other different conditions, thyroid diseases, chronic kidney disease. And one of the interesting one is the non-alcoholic fatty liver, which in the last 10 years, we are learning more and more about this condition. And actually, this happens commonly in patients who are obese. So again, it doesn't surprise me that it increases the risk of MIs and strokes. Next slide. So hypertension in the last 10 years, they changed the guideline now. It used to be that the blood pressure of 140/90 was okay. And now they're saying that it's not okay. Anyone who's got a blood pressure of 130/80 is now defined as stage 1 hypertension. Can you go to the next slide? I think this describes it very well right here. The next one. Yes. So if you look at this slide, it says the normal blood pressure should be 120/80. And elevated blood pressure is defined as 120/130. And you don't need any non-pharmacological therapy for that. However, as the blood pressure goes beyond 130/139, and then you calculate your estimated risk factor for acute MIs. And that can easily be done by your age, by your other risk factors. And if your risk factor over next 10 years is more than 10%, then you need to be started on medications. If your risk factor says, no, your risk is less than 10%, then you can still continue with your lifestyle modification. Stage 2 hypertension is defined as more than 140/90, and those patients should be on medications and non-pharmacological methods like lowering losing weight and eating right and doing walking and exercise. Next slide. Again, this is a huge topic, the dyslipidemia, we call it now, instead of hyperlipidemia, because we learned that not every patient have an elevated cholesterol. Some patients are at risk of heart attack, not because their total cholesterol is high or because their LDL, the bad cholesterol, is high, but because they have a low HDL. So HDL is a good cholesterol, and when it goes down, it increases the risk of acute MIs and strokes. So this is why the new term they want to use is the dyslipidemia. That is an abnormal cholesterol metabolism. But again, this slide was taken out from the guideline that came out about 5-6 years ago. And at the time, they use a hyperlipidemia. And again, it says that one of the recent cross-sectional study utilizing the coronary calcium score, and this is one other huge thing which came out in the last 10 years, indicated there is a 55% to 41%, 20% higher prevalence of hypercholesteremia, combined dyslipidemia, and low HDL, respectively, in patients with elevated calcium score. So what calcium score is that we used to see the patients who would come in and we do the angiogram and find the plaque, 30%, 40% plaque built up in their arteries, or they have one artery completely occluded. So the emphasis was given to find out how do we identify patients before they come to a cardiologist when the artery is about to close. So they came up with this new technique called calcium scoring CT scan. What this CT does is it calculates the amount of calcium you have in your arteries and gives a percentage and give you whether there are three main arteries, LAD, left circumflex artery, and the right coronary artery, and how much calcium you have. What they learn is the patients who have a higher calcium score, they have a 55% chance of dyslipidemia. Again, there are a lot of, still there a group of physicians who do not believe on the calcium scoring. The studies have shown that if you have a higher calcium score of more than 100, then it increases the risk of acute MIs in the next 10 years. And therefore, what they're suggesting is a person who's having a calcium score of 100 and LDL of, let's say, more than 100, that person should be treated more aggressively and bring their LDL level down. Can you go to the next slide?
Sure.
Okay. Oh, this one. So these are all the risk factors. Whenever we decide which patient should be treated for dyslipidemia, you have to calculate their what is called as a Frankenham risk scoring system and find out what is the risk of heart attacks or strokes in the next 10 years. And those are based on other risk factors, including the smoking, hypertension, and low HDL, family history, and age of more than 45 in men and 55 in women. And if you calculate the risk, and if you got two risk factors, then your target to bring the cholesterol down changes. For example, if the LDL of 160 will be fine in some patients, and LDL of 160 is not okay in many other patients. Okay, so this is a slide. I think you got yeah, you went through it. Can you go back again on this slide? No, next one. And next one. Yeah, this one right there. So what this guideline wants us to do is that before you subject the person to a medication, you need to calculate the risk scoring system. And then what you do is you find out whether the person has any of those conditions, whether they have a clinical coronary artery disease, symptomatic carotid artery disease, or any other peripheral arterial disease involving the lower extremities or abdominal aortic aneurysm. If they have any of those conditions, then the cholesterol number that we should target changes. And then go to the next slide now. So yeah, once you identify those conditions, then you have to calculate the risk based on their other risk factor, including hypertension, family history, and age. And then now go to the next slide. So basically, if someone has more than two risk factors, then if someone has been diagnosed with a diabetes or coronary artery disease, like heart attacks or anything like that, then their target LDL, the bad cholesterol, should be less than 100. And if we cannot control that with the diet, then you have to start the medication less than 130. In fact, nowadays we are saying even with the 100, you need to start them on medication and bring it down to 17 patients who have a coronary artery disease and stents. And person who have a two risk factor, but no coronary artery disease and no diabetes, then their target should be that you can continue to do diet until 130. If they are still more than 130, then you need to start them on medication. If someone has no risk factor or only one risk factor, then their target LDL, the bad cholesterol, should be 160. You can start doing diet. If their number is 160, try to bring it down to less than 160. If they still stays more than 160 after 3 months of diet therapy, then you can consider starting them on medication. If their number runs 190 or more, then you need to start them on medication regardless of their numbers. I think I would stop here. I just did 5-6 slides because I was told that we will have only 10 minutes, right? So if you have any question, let me know. This is the last slide, yes.
Great presentation. I really appreciate it. I have a couple of questions if you have a couple of minutes to talk about it.
Sure.
So tell me one thing. So basically, if somebody who is 75, 80 years old, correct, comes in,
Yeah.
and what is your recommendation for cholesterol lowering drugs like Lipitor? You know, there's a lot of controversy with Lipitor and all those lowering drugs. Uh, so what do you recommend to them if somebody who is 80 years old comes with a higher cholesterol level?
So again, you do risk scoring on them. If somebody is 80 years old and diagnosed with a coronary artery disease, or he's diabetic, then I think it makes sense to keep them on cholesterol lowering medication. But if someone has less than more than two risk factors, if they are not diabetic, but they have two other risk factors, they are hypertensive, or they have a abnormal cholesterol which is more than 160 LDL, or they are obese, um, then in those patients you can consider targeting the medication, but not very intense cholesterol lowering medication, because after age 80 the statin therapy has been associated with the increasing risk of side effects to the liver as well as to the muscles. It can cause rhabdomyolysis. And many of the patients who do not have coronary artery disease and they enjoy a healthy lifestyle, I tell the patient it's fine not to take it and just keep doing diet and exercise and bring your cholesterol down. However, if they have more than two risk factors, then we need to offer, according to the guideline, the medication first. And if there is no side effects, always we can start at the very low dose. Now, one more thing came out about 7 or 10 years ago was that what is called as intense statin therapy. Intense statin therapy was that instead of starting the cholesterol lowering agent at 10 milligram, you're supposed to start them at 80 milligram. Now, I never do that with the patient who is 80 years old. You always should start at a very low dose and keep an eye on their cholesterol numbers as well as their liver enzymes and the CK level. If they stay normal, then you can go up to 20 milligram and bring their LDL down to target. If if they start getting the side effects of the muscles, or you see a liver enzyme not being normal, then I go down to the half of the dose and then stay there. But again, according to guideline, we have to offer them if they have more than two risk factors. But if they're having side effects, then immediately stop that.
Yeah, that's great. That's a very useful information because there's a huge debate on that. We in geriatrics have issues with that, and that's I think so. That's yours on the point about that. The other thing is there any medication that basically remove the cholesterol from the vessels? You know that once your cholesterol is deposited, you know that is permanent. And of
Yeah.
course, with all the Lipitor and all those medications, what we're doing is making sure that more cholesterol is not deposited. That's why we look at the calcium level scoring, because the cholesterol comes with the calcium, and that's what we do that. So is there any medication that reduces, you know, take off the plaque from the vessels, and it's worth to do that?
No, I don't see. I mean, there's some, not to my knowledge, honestly. Now, when I was a fellow, we did, I participated in 2 studies myself, and there were 6 other studies that I did meta-analysis, and we presented there during my fellowship. And only one study showed that what we used to do was we used to do intense statin therapy, 80 milligram, and we also used to add Zetia, one other medication, and then we used to bring those patients back in 3 months and 6 months and put a special catheter called intravascular ultrasound IVUS into the patient's arteries, into the coronary arteries, and then measure the thickness of the plaque. We found out of 8 studies, 7 were negative. The plaque thickness did not change. Only one study showed out of, I don't know, I forgot the country. Anyways, one study showed that the plaque thickness did change and it went down. But 7 studies showed the plaque thickness does not change. However, one thing very interesting happened if you do a very good statin therapy and diet and exercise, the plaque morphology changes. The plaque can be high risk plaque and can be low risk plaque. Some of the plaques are soft and friable and they have a lipid core which can rupture and can cause acute MIs. However, then some of the plaques have more calcium on their wall and those become stable plaque. They become part of the blood vessel. So as you do statin therapy intense and diet and exercise, and then you do all the other medication and take care of yourself, the plaque gets stabilized. And the progression of the plaque definitely slows down. And in some patients, we saw there was no progression at all if you do a statin therapy, aggressive statin therapy. But to reverse the phenomena, we don't have any medication which can reverse the size of the plaque, which already is there.
Yeah, great point. I really appreciate that. Yeah, so the most important thing is that how to avoid people going to nursing home, correct? Because
Yeah.
basically, a lot of people get strokes and transient ischemic attack, TIAs. TIA is a big concern because basically, once you have TIA, which a lot of people don't realize it, that's a precursor for stroke, and people take it lightly and they are not aware of it. So that should be kept in mind to learn about TIAs to avoid stroke. And once you have stroke, you don't know how bad it can be. It can lead you to nursing home. It may be totally change your lifestyle. You may be as young as 50 years old, 40 years old, and in a nursing home, we see that a lot of time that they are handicapped and they cannot even eat by themselves because they need all the help. So that's a huge concern for in geriatric psychiatry. What we see is we have to give medication for depression also for these patients, so because they are so highly depressed. And in fact, people with MI and strokes, we do give antidepressant medication that helps them to recover much faster because they are going through turmoil and all those things. So that's very important to know that these numbers means a lot to our life and our significant others or our parents' life, because if you don't take care of it, we have a lot of issues to deal with it in future. And
One other interesting thing in the elderly population is that, I mean, I know a lot of emphasis is made on the cholesterol numbers, but one of the reasons those guys have a stroke is because of the paroxysmal atrial fibrillation, and it get missed a lot. So many of the elderly patients that I see, they get a stroke not because of the cholesterol numbers. So in fact, what I've seen is I'm not sure about the benefit of statin therapy after the age of 80, honestly, because I don't know what we're going to achieve by giving them high dose statin. But if they're going into atrial fibrillation, really that needs to be targeted right away, because that can lead to a series of strokes very soon. I have many patients that I saw clear change. They used to see me regularly every 6 months, and then they disappeared for 2-3 years, and then they came in as a totally new person. The only thing changed in them was they gone into paroxysmal atrial fibrillation. So when they go into AFib, then they start having mini strokes, and with those mini strokes, series of mini strokes, leads to multi-infarct dementia and all those things. So I think that's also needs to be considered in those.
Yeah, exactly. So one thing which comes up that people with COVID, we have seen that people who have some risk factor goes into atrial fib. You can see, and even with the medication of the COVID, the anti-viral medication, that can precipitate back into to atrial fib. And some of the people after the 5-day treatment go back to normal rhythm, and some don't because they have a risk factor. They were sitting there and the COVID pushed them into atrial fib. Do you recommend them to fix the atrial fib in that case scenario, or fix the risk factors before we fix the atrial fib, because that's a precipitation going back to atrial fib?
Yeah. So if the person with the COVID having mild LV dysfunction and they have gone into atrial fibrillation and their left atrial chamber size is stretched, then either you bring them back into normal sinus rhythm by doing cardioversion, or either pharmacological or doing a manual cardioversion by transthoracic, or you give them anticoagulation to prevent them from stroke, because they will be at high risk of strokes. So anytime if I see a COVID patient going into a FIB, I put them on anticoagulation until I see them that they're staying in normal sinus rhythm. Otherwise, yes, it will increase the risk of stroke.
Yeah, that's what we've seen, that we put them on anticoagulant medication, so avoid that. Other thing which I have heard, that you look at the rhythms. If the rhythms are okay, fix the risk factors before you convert back, like sleep apnea and all those things are very important. Yeah. If somebody has sleep apnea, they will go back. Even if you revert to now normal sinus rhythm, they will go back to atrial fib again. So you have to fix the risk factor. So that was very important. Yeah.
And one more important thing is make sure before you stop the blood thinner on them is that always do a 30-day monitor, because before you can say that they're not going into AFib, because many of those patients will be going into what is called as paroxysmal atrial fibrillation. When they come to see a doctor, they will be in normal sinus rhythm, but when they're running, jogging, or drinking, or whatever they're doing, then they're going to go into atrial fibrillation. So this is paroxysmal atrial fibrillation. The only way to identify is to give them a monitor, let them keep the monitor for 30 days, and then you can see if they're going into AFib at home or not.
So you're talking about Holter monitor, correct?
Yeah, so Holter monitor is only for 24 hours. So event recorder can stay with the person for 30 days.
Okay. That's
It's
very
like a patch. It's like a small patch. It sticks on the chest wall. They can remove it when they take a shower, and they can put it back again.
Yeah, that's good. Yeah, that's true.
Okay. Assalamu alaikum, Shoaib, Dr. Shoaib.
Assalamu alaikum.
Okay, this is Salim. Okay, so I have a question. When you put in like stents to the patients, is there any lifetime duration? Like 10 years they will last, or 15 years they last, or they are
No,
like...
so the stents, once you put the stent in, the only risk with the stent is immediate. When we do the stent, that they can thrombose, they can make a blood clot. That's why
Okay.
we used to keep them in the hospital for 24 hours. But now the quality of the stent is improved so significantly. Now they come with the drug-coated stents, so they don't
Okay.
go through the stent thrombosis. However, there is a phenomena called in-stent restenosis that can happen, and up to 2 years, in-stent restenosis incidence is about 5 to 7% in the new generation stents. If it doesn't
Okay.
happen in the first 2 years, then chances are nothing will happen to the stent, and it will stay open for the rest of your life.
Very
And
good.
one of the best example I gave it to the patients who come and ask me this question, I said, the very first stent procedure was done in 1971. And the guy who did the stent, he died after 4 years in an airplane crash. The cardiologist who did the stent. But the person who got the stent, about 2 years ago, he was brought to one of the cardiology meeting, and they repeated his angiogram. His stent is wide open still. So how many years? It was close to 50 years ago. So his stent is still
Right.
open. And those were
Wow.
old generation stents. So now we have a new generation stents, and they stay open for a long, long time.
Oh, okay. Okay.
But the
Very good.
stent is to remove the symptom. It does not fix the issue, correct?
Okay, so the stent has some impact on the mortality as well. It depends which artery and
Okay.
what location we are putting the stent. Not every stent will have an impact on the mortality. So what he's asking is that whether or not the stent saves the lives or not. So if someone having a stent because while he's having a heart attack, then stent is a life-saving thing. Then that stent saved the person's life. If somebody's
Right.
having what is called as unstable angina or non-ST elevation MI, that he came in the hospital and his artery is 99% blocked, is about to close down, then stent is a life-saving procedure. Now, patients who are having what is called as a stable angina, that they are fine at home and they all worried about their health and whether something is going to happen to me or not, then they go to a doctor, they get a calcium scoring, they did a stress test and it's not normal. And then they came to me and said, do an angiogram. When we do an angiogram, we find a lesion. What do we do? Because he's not having angina. Those patients, we are not supposed to put a stent unless this lesion involves a proximal LAD. If it involves a proximal LAD, the main artery of the heart, then I can put the stent. But other arteries I'm not supposed to touch because it has no bearing on the patient's mortality. It has no impact on the patient's quantity of life or quality of life because he's not having a lot of symptoms. If somebody's having a lifestyle limiting angina, then the stent will relieve the angina, but it will not prolong somebody's life. It will only relieve the angina. Because the process which is causing the blockage is going through. You're still having a cholesterol buildup. So you need to control that process. You need to slow down that process by doing more walking and exercise, control your diabetes, keep your cholesterol down and control your blood pressure and all those things.
Okay. No, so I was wondering just because once you started this presentation and I'm a little bit a data guy. So I was just wondering, long time back I read that like a little over 500,000 people, they died just because of, heart attack or cardiac arrest, etc., or heart-related diseases. But now you are telling us that it is like 850, and out of that, 650 goes because of cardiac arrest or heart attack. So I'm still wondering one thing. Maybe population is also growing. I can understand, but it's not that much anyhow. But the second thing is, I'm still wondering that a lot of stents been going around like from last 20 years, at least I could say. And still the death rate is so high. So it means those guys actually not get a chance to have some stents done. Probably that's the reason.
So yeah, it's an interesting question. So if you look at the AHA, American Heart Association website, they're going to say the incidence of the mortality, cardiovascular mortality, has gone down before the COVID in last 1 year. Before COVID in 1 year,
Okay.
1 year before the COVID. However, since COVID, it may have changed. I don't know.
Mm-hmm.
But to answer the question, I think the interesting thing is that we're looking at the mortality of cardiovascular related. Eventually, human beings are going to die, right? We're not going to live
Correct.
forever. So what cardiovascular innovations have done is the stents technology and all this, it has prolonged people's life. So instead of average lifespan of 60, now the average life people are living at 80s and 75. You see more geriatric people. It's all because of these technologies. We can put a stent person now, instead of dying at 56 when he came in, I put a stent, he's going to live for 10 more years now. Who knows in 76 or 80 what's going to happen to him. But so we just prolonging the life. We cannot modify the disease to say, okay, this is never going to happen and he's never going to die because of the heart attack. Eventually, human beings are going to die because of either the heart is going to stop because of the arrhythmia, or the heart is going to have a major heart attack because the artery is going to give up on him.
Okay. So is there any way that we could go and do some sort of every 5 years to see if heart is really healthy, or to have some kind of a, numerical value which says that if it is more than 70, just like your calcium test, so if it says like 70 or whatever number is the threshold, if it is more than that, then heart is healthy and strong. If it is
So
less than that,
yeah, so I think
regardless, even if people or the person does not see or feel any kind of a heart disease.
so the best thing to do is actually the calcium scoring is a big hype. I know right now people want to do it, but it does not actually give you any insight into the mortality. It will not tell you that if your calcium is 0, that person is going to live for next 20 years. No, I've seen patients with a calcium score of 0 and they're coming in the hospital 2 weeks later with a heart attack. So those are totally different things. I think the best test to see which has impact and which can give you your chances of having any major issues with your heart in the next 5 years is the simple exercise treadmill test, ETT. If you do a ETT and walk on the treadmill for more than 7 minutes and achieve the workload of what is called as METs, more than 7 METs, and you get your heart rate up to 85% of your target heart rate, then your chances of having a heart attacks or any heart-related death in the next 5 years is less than 10%, but it still is not 0. It's less than 10%.
Right.
That's based on the huge study done out of the Mayo Clinic about 30 years ago, and that is still stands. So when I see the patient and when they are not having any symptoms, I tell them just do a simple ETT if your age is 55 or 50. And if your ETT is good and your echocardiogram shows your heart pump is normal, then don't worry about it. Just go enjoy your life. Just enjoy a healthy lifestyle.
Right. Okay. Got it. I think you cleared a lot of things, really, Dr. Shoaib. Thank you.
Okay. All right. Thank you so much. Any questions? Hello?
Yeah, anybody has any other questions? So looks like nobody has a question. Dr. Shoaib, thank you very much. I know you're on call and now you have to go back to the patients. I wish you all the best and looking forward to seeing you in future. Thanks. It was a great presentation.
Thank you.
Yeah,
Appreciate
mashallah,
it.
it was a very good presentation.
Appreciate it.
Quite
Thank
a
you so
learning.
much. Thank you.
Jazakallah.
Jazakallah.
Assalamu alaikum.
Assalamu alaikum.